Thank you very much. Before I start, apologies. I have very nice videos in my PowerPoint presentation, which you're not going to see today. It does seem to work. I think it's something to do with the age of my video files and how young PowerPoint is, or whatever. But anyway, we're going to talk about optimal investigation and medical management of patients with heart failure. And what I'm thinking about here is really the patients who present to me who are short of breath. It's not acute coronary syndromes, they don't really usually have chest pain and so forth. It really is a genuine heart failure and what I would normally do for them. So patients with breathlessness and left ventricular dysfunction maybe come to my clinic with new diagnosis of heart failure or referred as an inpatient. And obviously there's a line of therapies, medical therapies, implantable devices, cardiac defibrillators and CRT, and then surgery. Conventional surgery I'm not really going to talk a whole lot about, and then obviously ventricular assist devices and transplantation we're going to hear a lot about today. So just to take a step backwards and the underlying pathophysiology of the failing heart is important to understand, because understanding that, then you understand why we give all our treatments, that is the ACE inhibitors and beta blockers and so forth. And essentially there's left ventricular dysfunction due to some insult, whether it's a virus, familial cardiomyopathy or a myocardial infarction. And the key is that results in neurohormonal stimulation you see down there at the bottom. And it's the neurohormonal stimulation then that has the adverse effects, increasing peripheral resistance. That makes the work of the weak heart ejecting harder, and then has direct effects on the myocardium, that remaining myocardium that's still alive, causing left ventricular remodeling. So, I mean, if you look at it in evolutionary terms, shock is a situation where you have hyperadrenergic neurohormonal activation. So when you lose a lot of blood, septic shock and so forth, it preserves perfusion of vital organs and so forth. Congestive heart failure, however, is a state of permanent shock. And whereas in the acute myocardial infarction, it may preserve perfusion of vital organs, the issue is that it's going on for a very long time. And the body hasn't evolved to know how to adapt to a chronically failing heart. And so there's neurohormonal activation for a long period of time, and those secondary effects are what further damage the heart. So the typical scenario is a patient has a myocardial infarction maybe 10 years ago, and they get lost to follow-up, and then they end up in my clinic. They may have had an ejection fraction of 35% after the infarct, but they come back to my clinic 10 years, they've just been following with their GP, they've been on a bit of beta blocker, a bit of ACE inhibitor, and now their ejection fraction is 10%. The question is, why has that ejection fraction gone from moderate dysfunction to severe dysfunction? They haven't had any further coronary events. The issue is that the neurohormonal activation that has essentially destroyed the rest of the heart that was working after the infarct. Here we show evidence that there is neurohormonal activation in heart failure. Yellow is normal, and the orange is heart failure. Norepinephrine, that's noradrenaline, renin activity, vasopressin, endothelin to the far right, all powerful vasoconstrictors and neurohormones that do damaging effects to the heart. Atrionatric peptide there, second from the right there, that's a compensatory hormone, but just doesn't do enough to help ameliorate the effects of chronic neurohormonal activation. So acute neurohormonal activation increases blood pressure, preserves perfusion of vital organs. That's essential to get over acute shock of various situations. But chronically, that's the problem. It increases afterload, reduces your stroke volume, causes myocyte necrosis and apoptosis, and causes sodium retention, which is the hallmark of fluid retention and the symptoms of congestive heart failure. Here we see slides showing that concentrations of plasma norepinephrine, red being the highest, green being the lowest, relating to outcomes, and we can see there over a period of time that those patients with the highest levels of norepinephrine or noradrenaline have the worst outcomes. So more neurohormonal activation, worse survival. And this has been described, the actual clinical scenario of patients dying of heart failure following an event has been described over 100 years ago with Osler, a very famous physician who worked both in Canada, the States, and in Oxford. He described the situation I told you about. The patient has the myocardial infarction, has a rocky course and so forth, period of stabilization, maybe slow decline, and then enters the symptomatic and terminal decline phase of congestive heart failure. That's over 100 years ago. We know a little bit more now. We know that there's increasing neurohormonal activation, so we can measure levels of neurohormones and cytokines and so forth. And obviously we can do echocardiograms, and we can see that even during that period of stabilization, the heart is gradually dilating and becoming more dysfunctional before they become symptomatic. And obviously the idea is to, when we see our infarct patients, to give them as much neurohormonal blockade to ameliorate, to reduce the progression of congestive heart failure. It doesn't prevent it as much as possible. So again, just showing how outcomes are related to the degree of left ventricular remodeling, left ventricular diastolic diameter, left ventricular ejection fraction, divided up into quartiles, and those with the largest diastolic diameter, the worst ejection fraction, have the worst outcome, and they're the ones with the greatest neurohormonal remodeling. And we have over 20 years of evidence underlying the use of inhibition of neurohormones in congestive heart failure. And so this slide encapsulates two of the very important slides. On the, this slide here on the left-hand side is the original consensus trial, severe heart failure, essentially mostly class 4 heart failure. You can see it's enalapril versus placebo, a relatively small number of patients, tremendous mortality. So basically this is what the mortality was before we had heart failure medicines. You can see at 12 months there was over a 60% death rate. Enalapril had a significant benefit. Then solved treatment, which was moderate heart failure. They had to use a larger number of patients, obviously. The benefit wasn't quite as much, but nevertheless, significant improvement. And so ACE inhibitors are used in all classes of congestive heart failure. Beta blockers, when several of us in this room were in doing our clinical pharmacology, if we said we'd use a beta blocker in congestive heart failure, we wouldn't have made it through to here. But things have changed a lot. And again, because beta blockers are most potent inhibitors of neurohormonal activation, the most important medicines that we have. And this slide encapsulates results from several important clinical trials. And these clinical trials are probably going to underscore, be the most important clinical trials of my career, because the amount of beta blockers I'd be giving out. US carvedilol trial just came on stream when I was finishing my training, and that was in patients with predominantly class 2 to 3 heart failure, significant benefits. Cibis was bisoprolol, we used a lot of that in the United Kingdom, beta 1 selective beta blocker. Merit-HF is a long-acting version of metoprolol, which is not available in the United Kingdom, but similar obviously to bisoprolol. Copernicus was another carvedilol study. Carvedilol is a non-selective beta and alpha antagonist, and it was trying to address the issue, are some patients with heart failure just too sick to take beta blockers? So they were a sicker group of patients. They weren't exceptionally sick, but they were more class 4 and so forth. A lot of them were in intravenous diuretics, decompensated heart failure, again, significant benefits. Aldosterone antagonist, spironolactone, has been around for donkey's years. This study is over 10 years old now, and the rationale behind using spironolactone in heart failure is it inhibits aldosterone. Aldosterone is increased in heart failure. It is reduced by ACE inhibitors, but the effect is transient. It tends to go back up again. So addition of spironolactone on top of your ACE inhibitors and beta blockers also has significant benefits in heart failure. Spironolactone is a difficult medicine to use. A lot of our patients with heart failure have comorbidities, in particular renal insufficiency. In that situation, spironolactone can lead to very life-threatening hyperkalemia. So you do have to be careful about spironolactone. I'm more nervous about using spironolactone than beta blockers, whereas often it's the opposite outside people who are perhaps not used to using heart failure. And that is a problem with heart failure. There's a lot of medicines, and you have to be familiar to using them. So the people who aren't using it a lot and really just are maybe just too cautious, just don't have enough experience. And so there really is a need, and it's beginning to become apparent in this country that there's a need for specialist heart failure people to take care of lots of these patients. Diuretics, you've got to give enough. That's the bottom line. People are again afraid to give diuretics. They're afraid of kidney function going off and so forth. I don't worry about the kidney function. What really is a bad thing, a patient with swollen legs is not good. And I'd rather have a slightly high creatinine or whatever and have the edema gone because those patients are much better. And there is evidence underscoring that as well. You've got to treat them with enough diuretics. Right, so this is not going to work. Anyway, what I did show you was dysynchronous contraction of the left ventricle. So what has been recognized over the last 10 years or so that in some patients with left ventricular dysfunction, that not only is the ventricle not contracting properly, but it's dysynchronous. That is, one part of the heart contracts before the other, and there's a delay. And the idea behind cardiac resynchronization is that you can resynchronize this. And the hallmark of watching it is, of picking it up is, the hallmark of picking it up is on the ECG. It's after so many investigations, left bundle branch on the ECG is the most important. And so this is the biventricular pacemaker. It's slightly old. The wires are thin now. That's going out the coronary sinus and so forth. So in well-selected patients, this certainly has benefits. Left bundle branch block is important. Atrial fibrillation is not necessarily a contraindication. Some patients are too sick for it, though. Again, these are all just going to blank out. But basically, this was a patient who had a dysynchronous, dysfunctional ventricle. He got a pacemaker, and 6 months afterwards, and he was doing a lot better. So ICD for primary prophylaxis, very, very important. Patients with sustained permanent left ventricular dysfunction due to ischemic heart disease or other causes. There's lots of evidence underneath it, underscoring it. I'm not going to go into it. We have restrictive guidelines in NICE where they try to restrict it to patients just with left bundle branch block and so forth. That's quite old. Hopefully that's going to be reviewed in the future. Certainly if you speak to most of our electrophysiologists, you present them a patient with left ventricular dysfunction, that's not going to get better for another reason. They'll likely put in an ICD for primary prophylaxis. I've had too many patients die on unstable medications from sudden cardiac death. Evidence underscoring cardiac resynchronization. Probably the most important study was the CARE-HF study. And the benefits of this study was that they very carefully selected the patients. They went for that left bundle branch, that was the key thing. If it was over 150 milliseconds, they got a CRT. If it was between 120 and 149, they had what's called a dysynchrony echo. So they very carefully selected those patients. And that was the first time that they showed a significant benefit in mortality. So CRT in well-selected patients really is an important thing. So investigations, I think this is my last slide or two, for the newly diagnosed heart failure patient. Echocardiogram, yes, they all get echocardiograms. Systolic versus diastolic dysfunction. Diastolic dysfunction is becoming so important in heart failure. At least 50% of the patients I see have diastolic dysfunction. It's incredibly difficult to treat. There's no evidence base underscoring it. All what I've shown you today has been systolic heart failure. So echocardiogram is very, very useful. MRI, using more and more MRIs in our patients who present with left ventricular dysfunction. You can pick up an unheralded infarct, obviously signs of myocarditis, or sometimes you pick up strange forms of infiltrative cardiomyopathy. And on top of that, get very accurate measurements of left ventricular function. NT-proBNP is now very clearly recommended in recent NICE guidelines. It's a pain in the neck. It really is. It's a very variable measurement. It stuffs my clinic full of elderly patients with a bit of swollen legs and a moderately high BNP, and you do an echo and they might have slightly enlarged left atrium and that's it. So it sounds to me like the guidance, the NICE guidance, has gone ahead of the science. We're using BNP before we really understand if it is any use at all. It is used in some particular situations, but I think that needs to be revised. Clinical assessment, in my mind, is the most important thing, the NYJ class. At the end of the day, if a patient can run up the stairs, go 2 flights, does that work, and so forth, things can't be too bad. If they're doing poorly, then we really have to think about it. Routine assessment ischemia. In these, talk about these breathless patients, I don't normally do it unless there's a particular reason they're getting chest pain and so forth. So I don't necessarily do it. Community heart failure nurses, this is all a lot of work and someone else has to help me out, and that's who does it. So, one more slide, sorry. We'll get there. There we go. So who to refer for specialist heart failure treatment? That's my game. Refractory symptoms, again, NRHA class. Those patients who aren't doing well. Early warning signs, kidneys going off, and the symptoms are with it. CRT, wide QRS, ICD for persistent left ventricular dysfunction, transplant VADs, relatively free of comorbidities, consider transplant or VAD, discuss with your local transplant unit. It's really important to keep in touch with them, and that's what I encourage for our local referrals and so forth, is just give me a call and we can talk about it, because the thing that we really hate and dread is patients calling up and it's just too late. And they've gone through some sort of high risk revascularization and now been in ITU for 6 weeks and they've got MRSA and they're on the ventilator. Sorry, thank you very much for the call, but we can't do anything. Revascularization, again, so if you're thinking of doing a very high revascularization, maybe have a chat with your transplant centre and just see if they've any other ideas. Don't leave it too late. Thank you very much.